Good evening, ladies and gentlemen. Thank you so much for inviting me to address you as part of the Pakistan Society of Nephrology. I know that this is an important meeting, and I really wish I could have been able to participate in person. Unfortunately, this year that was not possible, but I do hope that in the future it will become possible for me to participate and we can get to know each other up close and personal. I know that for the past several years, you all have been working to increase the penetrance of peritoneal dialysis in your country, the availability of this important therapy for end-stage kidney disease. One of the issues that must be addressed, obviously, is that of peritoneal dialysis-related peritonitis. And that's what I'd like to discuss with you today and see if we can perhaps make it easier to hopefully prevent peritonitis and deal with it when it does arise. Peritonitis is important, not only because it accounts for a significant percentage of the transition from peritoneal dialysis to hemodialysis, but as you'll see in this slide in a study from Australia, its association with subsequent mortality. Here you see the likelihood for a patient having had peritonitis prior to death as a function of time before death. And you can see that in the 30 days prior to a PD patient's death, there was a 6-fold likelihood that this patient had peritonitis compared to randomly selected times throughout the year. And this relationship persists as far as 120 days prior to death, where there is still a twofold likelihood of having had peritonitis. So what I'd like to do with you today is the following. I'd like to discuss the manner in which we diagnose peritonitis, how to prevent episodes of peritonitis, how to manage it once it does occur, and very briefly at the end, we'll discuss the monitoring of peritonitis rates. So how do we diagnose peritonitis? The standard definition you probably are all familiar with as listed in the ISPD guidelines. I will give a shout out at the end, but let me point out to you again, or at the outset, the ISPD guidelines available at www.ispd.org under Education and Guidelines. They're open access and they're excellent. The most recent peritonitis guidelines as of now are 2016, but I can tell you that there is another guideline in press that will be coming out in PDI within the next few months. So the definition of peritonitis will not change. Peritonitis is diagnosed when 2 or more of the following criteria are present. Clinical features consistent with peritonitis, such as abdominal pain or cloudy dialysate, a dialysis fluid white count of at least 100 cells per cubic millimeter after a dwell time of at least 2 hours with at least 50% polys, both 100 cells and at least 50% polys, or number 3, a positive culture from the dialysis effluent. Note that any one of these alone is not sufficient grounds on which to diagnose the presence of peritonitis. As I mentioned, you want to sample fluid after at least a 2-hour dwell so that there has been time for the fluid to equilibrate and for cells to penetrate the fluid. At the same time, you do not want to take fluid from an abdomen that has been dry for several hours and many cells will have accumulated. And you want to test the PD fluid for a cell count with differential, gram stain, and culture. Ideally, one should centrifuge at least 50 ml of the peritoneal fluid and resuspend the pellet in 3 to 5 ml of sterile saline, inoculate solid media and blood culture media for aerobic, anaerobic, and microaerophilic organisms, or just inoculate blood cultures at the bedside. I should point out that what's coming on the horizon is another method for bedside diagnosis of peritonitis. This is a dipstick, if you will, called Periplex. It utilizes lateral diffusion technology, similar to that being employed now with COVID testing. And you can see here in the upper panel that the left-hand line is a control, that's a negative test, and then either a single line for MMP8 or IL-6, or certainly both, constitutes a positive test. MMP8 is a matrix metalloprotease 8, which, as you can see on this slide, is far more likely to be present in patients with peritonitis at a higher level than in patients without peritonitis. Similarly, interleukin-6 indicates the presence of peritonitis. Notice that this is a logarithmic scale. And here you have the areas under the curve for IL-6 and MMP8 in the lower panel, and you can see they are fantastic. And the net results is that you have a sensitivity and specificity of 98 and 88% each, but most importantly, a negative predictive value that exceeds 98%, i.e., if you do this test on a patient with suspected peritonitis and the test is negative, you have a higher than 98% probability that the patient, in fact, does not have peritonitis. This is not yet commercially available in the United States. I don't know if it's commercially available at all, but when it is available, I think it will help in the diagnosis of peritonitis. Final diagnosis, of course, will still be dependent on culture, so that we have an organism and know how to treat. Do keep in mind that not all that is cloudy is peritonitis. There is a differential for cloudy peritoneal fluid. You can see it here. I'm not going to read this entire slide, but you can see that there are many non-infectious causes of cloudy peritoneal fluid that must be taken into consideration. That said, however, when cloudy effluent is present, you should presume it to be due to peritonitis, and you should treat it as such until and unless the diagnosis can be confirmed or excluded. Obviously, we want to successfully treat peritonitis, but even more so, we would like to prevent peritonitis. In order to prevent peritonitis, one must understand the pathophysiology. There are 5 routes for contamination of the peritoneal cavity. Intraluminal, from touch contamination and an organism traversing the interior of the PT catheter. Periluminal, for example, an exit site infection, and then tracking alongside the catheter into the intraperitoneal space. Transmural infection across the bowel wall. Hematogenous spread from a source, frequently dental, with a little bit of a transient bacteremia, or ascending from elsewhere in the genitourinary tract. And we have to worry about fungal superinfection, as we shall discuss. There are some things that can be done at the time of catheter placement to reduce the likelihood of subsequent peritonitis. The most important one is the use of perioperative antibiotics. A single dose of either a first-generation cephalosporin or vancomycin should be given at the time of catheter placement. There are other things recommended that you may read here. Transfer set placement in the OR under sterile conditions, keeping the exit site away from skin folds. Definitely, the data is pretty good that we should have the exit sites directed inferiorly or laterally, not superiorly. And these are things that I would endorse. And then there are those things that simply don't matter. The type of catheter, the catheter design, 1 cupped, 2 cupped, swan neck or straight intercuff segment, curled tip, coiled tip, straight tip, doesn't matter. The nature of the person who inserts the catheter, the method of catheter insertion, whether the catheter external limb is buried, the so-called Popovich technique, Moncrief-Popovich technique, none of these has made a difference in the likelihood of subsequent peritonitis. Now, periluminal contamination, Intraluminal contamination is, of course, important, and for that we want to avoid accidental contamination. If a contamination does take place, if it's a wet contamination, i.e. the transfer set is open and there is communication between the external environment and the intraperitoneal space, then you need to give antibiotic prophylaxis. If the clamp remains closed and the transfer set, the tip of the transfer set has become contaminated and the patient is aware of it, if they keep that closed, do not perform an exchange, and then you exchange the transfer set, no antibiotic is needed. Periluminum contamination, as I mentioned, with an exit site infection is a risk for peritonitis. And here you can see that information clearly diagrammed, that the hazard ratio for developing peritonitis within 15 days of an exit site is tenfold. And even within 60 days of a prior exit site infection, remember that exit site infection may not be fully eradicated. So if the infection began, for sake of discussion, on January 1st into February, there is still a risk for subsequent peritonitis. Therefore, it is recommended with strong level of evidence in the most recent catheter-related recommendations, 2017, it is recommended that there is daily topical application of an antibiotic cream or ointment to the catheter exit site. And this came about as a result of a number of studies in the 1990s and early 2000s looking at the use of mupirocin. And you can see that there is an average of about 60% reduction in the likelihood of exit site infection when one uses mupirocin applied at the exit site. If you get rid of the high outlier and the low, you can see that the others are all between 60 and 68%. Subsequent to the mupirocin study, there was a randomized controlled trial looking at gentamicin versus mupirocin, and you can see here that there was a lower rate of exit site infection, both gram-positive and gram-negative with gentamicin. There was the same rate of Staph aureus exit site infection, but importantly, as shown in the lowest bulletin, the last bulletin, there was a lower rate of peritonitis with gentamicin, 0.34 per year versus 0.52 per year. And this was true for gram-negative peritonitis as well as gram-positive, and there was, importantly, no Pseudomonas. Apart from mupirocin and gentamicin, there have been a number of other agents recommended for the prophylaxis of exit site infection, and you see them listed here, things such as ciprofloxacin otologic solution, antibacterial honey, sodium hypochlorite, etc. And the official recommendation from the ISPD is no cleansing agent has been shown to be superior with respect to preventing catheter-related infection. So whatever it is you can most readily have available to your patients, at least cost, the thing that they will be most compliant with, that's what I would recommend. As I mentioned, there is transmural infection, there is ascending infection from the genitourinary tract, and therefore it is recommended that antibiotic prophylaxis be given prior to colonoscopy or prior to invasive gynecologic procedures. And here you can see some of the data for peritonitis relating to colonoscopy. Not that every last episode will be prevented, but you can see here that of patients who received antibiotics, 18 patients who received antibiotics, they did not have peritonitis, while in patients who did not receive antibiotics, there were 5 episodes of peritonitis. It is also recommended that one keep the abdomen dry, i.e. not have any peritoneal fluid within the abdominal cavity during the procedure, and if possible, for 1 to 2 nights thereafter. Remember, hemodialysis patients skip dialysis for 2 days all the time. There's no reason that we couldn't, on one occasion, have a PD patient skip 2 nights of dialysis, 2 days of dialysis. We also know that transient bacteremia is common after dental procedures. And there is at least anecdotal experience, strong anecdotal experience, that this may lead to peritonitis. And it is therefore believed that prophylactic antibiotics before extensive dental procedures may be reasonable. And I certainly do that if there's going to be an extraction, if there's going to be a deep cleaning associated with some bleeding, there's the risk for bacteremia, and we administer prophylaxis. Other strategies to prevent peritonitis: avoidance of hypokalemia, avoidance of constipation, and avoidance of H2 receptor blockers. And I'll show you a little bit of data. This is data from Hong Kong looking at the prevalence of peritonitis in patients with a potassium of 3.5 or better, and in patients with a lower serum potassium. And you can see that there's about a 3.5-fold likelihood of peritonitis in the patients with hypokalemia. And this has been subsequently corroborated in a much larger study by the PDOPS group. And you can see that patients who have hypokalemia less than 4 for 4 months or longer, excuse me, this was 4 months or longer, have a increased likelihood of peritonitis. I think I misspoke. It's a K less than 3.5, but for 4 months or longer. And finally, the relationship between constipation and peritonitis, or next, constipation. You can see here that in comparison to the patients without constipation, there is a significantly higher likelihood of peritonitis over 2 years in the patients with constipation. And then finally, the role of H2 receptor blockers. And again, you can see on the left, the risk of peritonitis, on the right, mortality from peritonitis, compared to patients using no anti-acid therapy or patients using a PPI, shown in the dotted line. The patients using an H2 receptor blocker in the thicker dashed line, this lower line, had a higher probability of developing peritonitis, a higher likelihood of mortality from peritonitis. And in another study that is still in press, not yet published, but it's been shown that H2 blocker use increased the risk of peritonitis after gastroscopy by nearly 4-fold. As I mentioned earlier, we do need to worry about fungal peritonitis, and it's worth noting that the majority of cases of fungal peritonitis follow on the heels of antibiotic administration for some other reason, not just for bacterial peritonitis, but if you have a patient with a wound ulcer, a foot ulcer, and you treat that patient with antibiotics, there is a higher likelihood of fungal peritonitis in the aftermath of that. And we therefore recommend fungal prophylaxis when patients are treated with antibiotics for any reason. It can be done with nystatin, it can be done with fluconazole. It's important that you do so for 7 days after completion of the antibiotics, because of course the antibiotics are still on board for a period of time. Despite our best efforts, patients will develop peritonitis. So how do we manage that? It's important to know the microbiology of peritonitis. It is approximately 60% gram-positive organisms, maybe 25 to 30% gram-negative organisms, and then there are always those that are going to be culture negative that we'll talk about. The gram-positives are most commonly coagulase-negative staph, Staph aureus, strep, enterococcus, and there are diphtheroids. There are Corynebacteria that are pathogenic, and if that's what you grow from the fluid of a patient who presented with symptoms and had an elevated white count with polys in the fluid, it is pathogenic. Don't let the lab tell you otherwise. There are, of course, gram-negative bacteria, the Enterobacteriaceae, such as Klebsiella, E. coli, etc., Pseudomonas, Acinetobacter. And then there are the rare anaerobes, Mycobacteria, MTB, not common in the United States. In 35 plus years of doing peritoneal dialysis, I've seen one case of mycobacterial TB peritonitis, but I know that in India, so in the same geographic region in which you are, they have many cases of tuberculous peritonitis. So I would suspect that it's not rare in Pakistan. And then, of course, there are fungi or yeasts. So the empiric therapy, when a patient shows up with abdominal pain, cloudy fluid, and has 187 white cells, of which 92% are polys, you want to start therapy. You want to cover empirically for both the gram-positive and gram-negative organisms. And as I mentioned, you want to start antifungal prophylaxis. Your gram-positive coverage should be a first-generation cephalosporin or vancomycin. Your gram-negative coverage, a third-generation cephalosporin or an aminoglycoside. Now, if you know that your patient has recently had a methicillin-resistant Staph aureus infection, or if your center has a high prevalence of MRSA, then you might consider the use of vancomycin rather than a first-generation cephalosporin for your gram-positive coverage. I would point out also that there is some relatively recent literature regarding the use of cefepime monotherapy being equally efficacious as the combination of a first-generation and third-generation cephalosporin or vanc and a third-generation cephalosporin. What about the route of antibiotic administration? Should it be IP or IV? Most experts recommend IP, the intraperitoneal route. This makes sense clinically because you're delivering the antibiotic to the site of infection and you get a higher local concentration of the antibiotic to exceed the minimum inhibitory concentration with which to kill the organism. Not to mention that the patient can give themselves the IP antibiotics at home. You don't have to place a line. That said, I can't stand here and tell you, or sit as the case may be, and tell you that the evidence for this is strong. It is not. But it is our practice, I can tell you that, and for most of the people that I know of. One thing that is important is whatever route you choose, to administer the antibiotics as quickly as possible, as promptly as possible, as this study would recommend. This is a study out of Australia in which they demonstrated that each hour of delay in administering the antibiotic from the time of presentation to the time of antibiotic administration, so between the time that the patient first shows up to the time that they get the antibiotics, every hour you delay increases the risk of PD failure or death by 6.8%. So you want to get the antibiotics in as quickly as possible. So the intraperitoneal route trumps the IV route, but early administration trumps the route. If you're able to get an IV quickly and administer parenteral antibiotics quickly, and the IP will take you longer, administer it IV. What about PO? We use PO after several days of IP, once we have sensitivities and the patients are demonstrably doing better, but not for the initial empiric therapy. As I mentioned, early management is key. You want to start your IP antibiotics as soon as possible. Of course, you want to try hard to get your microbial specimens before you initiate therapy. When you put fluid in the peritoneal cavity, when you put the antibiotics into the peritoneal cavity, allow the dwell for at least 6 hours so that you have appropriate absorption. Again, make sure you have both gram-positive and gram-negative coverage, basing your selection on the historical patient and center sensitivity patterns. I mentioned that it's okay to use an aminoglycoside as part of your empiric therapy. People say, well, what about the risk of impairing residual kidney function? It's a good question. It's a valid concern, but the answer is that the short-term use up to 2 to 3 weeks of aminoglycosides appears to be safe. It is, of course, inexpensive, and there is no correlation with a decline in residual kidney function. You do want to be careful with vestibular and ototoxicity. You want to minimize the duration of the aminoglycosides to the extent possible and avoid repeated or prolonged courses. But if you need to use an aminoglycoside, don't shy away from it. And as long as we're talking about residual kidney function, keep in mind that especially for gram-positive or culture-negative peritonitis, we believe that culture-negative is most commonly due to gram-positive organisms. You need to worry about the residual kidney function because especially if you're using vancomycin, if you dose the patient every 4 or 5 days, assuming that they have no residual kidney function, when in fact they do have residual kidney function, the risk for treatment failure goes up. And here you can see this is a study out of Toronto, where as compared to patients with no residual kidney function, if they have 0 to 5 mils per minute, there's a higher risk. And if they have more than 5 mils per minute, the risk of treatment failure goes up further. So you do need to consider residual kidney function. As I already mentioned, culture-negative peritonitis, i.e. peritonitis confirmed by clinical presentation and the presence of a white count in excess of 100 with at least 50% polys after a dwell time of 2 hours. When those are present, but the culture fails to grow, it is nevertheless considered an episode of peritonitis. It's culture negative, and we should treat them. If the culture is negative at 3 days, still repeat the cell count and culture to see if maybe for some reason it failed to grow but will grow the second time. If the peritonitis is not resolving at 3 days, then consider special cultures for atypical organisms. What about repeating the cell count on day 3? There is an interesting set of studies that shows that if the effluent cell count on day 3 is in excess of 1,000, so then there's a 60 to 65% likelihood of treatment failure. I don't find this extraordinarily helpful because there's still a 35% to 40% likelihood of treatment success, but it does alert you to pay attention to what's going on and maybe check the cell count again on day 5, day 6, and see whether the catheter needs to come out. Remember, refractory peritonitis is defined as failure to clear the infection or reduce the cell count by day 5. Now, what if I told you that upon administration of antibiotics, the patient began to feel a bit better, and the fluid appeared to be improving for the first 24 to 48 hours, but then after that, both again worsen. The patient starts to get worse, and the fluid looks cloudier, and the cell count has gone back up. That should prompt you to think of what's called the spice organisms. You see in the blue caps highlighted. Spice organisms are bacteria, gram-negative bacteria with inducible chromosomally mediated beta-lactamases. So Serratia, Pseudomonas or Providentia, the indole-positive Proteus acinetobacter or Morganella, Citrobacter, and Enterobacter. These are the spice organisms. We had a case recently where we had exactly this going on. We had to treat the patient with imiropenem in order to eradicate the organism. Some reports of response with an oral fluoroquinolone or an aminoglycoside. Keep in mind also that there is something called secondary peritonitis, where it's not a primary bacterial infection, but you have appendicitis or a perforated viscus, diverticulitis, rarely a strangulated hernia. And when the fluid looks brownish like this, That's a clue. And lastly, as we've mentioned, we want to avoid fungal peritonitis. When it does occur, catheter removal is basically mandatory. The traditional therapy was amphotericin B and flucytosine. There is resistance to fluconazole. Not a lot know about the echinocandins. It is recommended that the catheter be removed, and we worry about treating the patient, not salvaging the catheter. The patient can always go to hemodialysis, and about 1/3 of the time, the patients can return to peritoneal dialysis. It should be noted that if you have to remove the catheter, we already talked about fungal peritonitis, but even if you have a refractory bacterial peritonitis and it's necessary to remove the catheter, patients can come back to peritoneal dialysis, and both patient survival shown on the left as well as technique survival shown on the right are similar for patients who have never been on hemo and those who were on PD, went to hemo and came back to PD. So PD-related peritonitis, remember, can often be managed in the outpatient setting. Hospitalization should be considered for patients with unrelenting pain, with ongoing nausea, vomiting, hemodynamic instability. If you suspect secondary peritonitis due to a bowel perforation or anything unusual in the presentation that prompts you to want to monitor the patient more carefully. If you have difficulty delivering IP antibiotics but could deliver IV, and the frail patient, someone you want to keep careful tabs on. And to close, just a few words about the monitoring of peritonitis rates. You want to monitor at least on a yearly basis. We now monitor on a monthly basis. It takes 3 minutes to review your peritonitis episodes, especially when you hope to have many months in which none of your patients have peritonitis. You review the rates, both for peritonitis as a whole, organism-specific rates. You review the percentage of patients per year who are peritonitis-free, and antimicrobial susceptibility patterns. As I mentioned, there are new recommendations from the ISPD in press, and that recommendation is tightening things a little bit. We used to say that the overall peritonitis rate should be no more than 0.5 episodes per patient year at risk. We now know that there are programs routinely achieving 0.2, so we're striving for better. 0.2 is difficult to achieve for many programs, but 0.4 is very, very reasonable. All over the world, there are programs achieving episodes a rate of 0.4 or lower. And similarly, we recommend that the proportion of culture-negative peritonitis should be less than 15% of all peritonitis episodes. As I mentioned, there are resources available at www.ispd.org under Education and Guidelines, open access. You do not need to be a member of ISPD, although I would encourage those of you who can to please join the organization, but you don't have to be a member to obtain access to these guidelines. The catheter-related guidelines dates to 2017. Peritonitis, new set coming in the next few months. For those of you who wish to learn more about peritoneal dialysis and all its various aspects, I invite you to join us in Singapore this coming August for the ISPD 2022. And to all of you, I thank you very much for your participation, for listening to me today. I wish I could be with you to take questions. Unfortunately, that is not possible. Have a wonderful rest of your evening.